Thank you for having me here at the IHI BMJ Australasia Forum, and thank you, Nana, for that wonderful introduction. As I speak to audiences all over the world these days, I've noticed an important tradition in many countries of acknowledging the place that they are speaking from and highlighting the history of the native peoples of that land. I love this tradition because in this increasingly virtual world where we have come unmoored from our geographies and when we can't physically be with one another, this tradition at least keeps us literally grounded to a sense of place. So with that in mind, let me tell you where I'm coming to you from today. I speak to you from Richmond, Virginia, where my family and I make our home. This land that I sit upon today was the ancestral home of the Powhatan people, the indigenous tribal confederacy that was here when the first English settlers came to found the colony of Jamestown in 1607. The Powhatan taught the settlers techniques of agriculture that have been used for centuries and have given us words in the English language like raccoon, tomahawk, and even the word wow. It was on their soils that just a few years after the founding of Jamestown that the first African slave ship arrived, starting what would become a massive transatlantic slave trade, the consequences of which we are still living with today. I tell you this story both to share with you where I'm from, where I live, where I work, and where I raise my 3 children, but also to connect us. And because later in this talk, I will come back to the challenges of creating better health for our nations and the vital issue of creating more health equity in our world. I want to start our conversation today with a story of a patient of mine. I first met Gloria before I became a physician, when I was a community health worker in Providence, Rhode Island, about an hour south of the town of Boston. Gloria had been diagnosed with AIDS, and for the first few months she was precariously ill, with a fragile immune system. Her physicians had made a deal with her. They would prescribe her a cocktail of aggressive medications that would likely save her life, but she would have to take her meds under supervision. They didn't trust her, you see, to take her medicines on her own. Instead, Gloria's doctors wanted to make sure she was taking her meds. I would be her supervisor. Gloria desperately wanted these medications. For her, they were literally the difference between life and death. And she was a single mother with 4 children that all depended on her in turn for their survival. Gloria had limited resources and limited options, so she agreed to the program. I began to see her every day for her morning dose, a chaotic time to be sure, as she tried to get her kids ready to go to school and herself ready to go to work. I was almost surely a nuisance to her, but she tolerated me with compassion. I was doing a job, she was doing a job. She took her 23 pills with me in 3 handfuls. I remember this vividly, even to this day. It was painful to watch her wince with every gulp of her medicines. But she and I faithfully completed our tasks. I documented as she gulped down her pills. Gloria was afraid of her disease and what might happen to her and her family if she could not go on. She would ply me for more information on her condition, on HIV, and I'd tell her what I understood. And she would tell me sometimes that she was afraid that her employer would find out about her HIV status and that she would lose the job that was keeping her family afloat. Occasionally, I came to see Gloria for her early evening dose, and there I'd see the parade of case managers coming in and out of her home to help her or one of her kids. All of us thought that we were saving Gloria, but none of us really were, and she was exhausted by all of us. One day, I had the chance to walk with Gloria on her way to her bus stop after the morning pill ritual. She asked me why the hospital was sending me out to see her. I tried to think of a good way, a polite way to answer, but I decided instead to tell her the honest truth. I said, because they think you are high risk, and they think you will develop resistance to these medicines and that you will fail them. My role was an extension of a health system that didn't really trust Gloria. She already knew that, of course, but she wanted to see just how much I understood yet. Gloria developed severe HIV infection in the years right after we had made amazing advances in the science of HIV treatment. Not quite curative, but the 3-drug cocktail combinations that we were using by the time I met Gloria had the amazing ability to save people from the brink of death and convert a life-threatening acute infectious disease into a chronic, lifelong ailment. And Gloria was an amazing patient. She took her meds dutifully and her immune system recovered. She got healthier, she gained weight, gained energy, and saw that she could live a healthy and long life. I eventually left Providence for Boston, but in one of our final encounters, I recall that Gloria shared with me that of course her life had been dramatically changed by HIV. And while she did not for a second wish that she had the disease, she had seen many ways in which the infection had given her new perspectives on the world and new perspectives on herself. She said, HIV once made me weak, and HIV has also made me strong. In the many years since I met Gloria, I have treated hundreds of HIV patients and thousands of patients with other chronic diseases. And many of them, at some point in their experience of illness, share in this dichotomous experience: the suffering, the uncertainty, the sheer peril of the unknown, and yet the transformative power, the courage, and the renewal. Khalil Gibran, the Lebanese-American writer, artist, and poet, once wrote at the turn of the last century, "Out of suffering have emerged the strongest souls. The most massive characters are seared with scars." A few weeks ago, I was speaking to a colleague of mine, Professor Leonard Berry. Len is a distinguished professor of marketing at Texas A&M University and a senior fellow at the IHI. Some years ago, Len published a seminal book about management lessons from Mayo Clinic, and more recently, he has just completed an extensive study into the successes and failures of modern cancer care. As with every conversation these days, Len and I began to talk about our families and how the pandemic has affected our personal lives and our work. And as we were doing that, Len said something to me that completely disarmed me, stopped me dead in my tracks. He said, "I'm not sure if I will live to see the end of COVID. COVID may well be our system's chronic disease." By this, Len wasn't referring to long COVID or the long-term clinical sequelae of the coronavirus infection, but instead, what he was saying was that perhaps COVID was in fact here to stay. Until as recently as July, many people here in the US were forecasting the end to COVID. This is an acute infectious pathogen, after all, and we were nearing the 70% immunization threshold that we had been seeking. Case rates were plummeting, and many believed that the end was in fact near. But with resurgence of the Delta variant, climbing case rates, hospitalizations now at all-time highs, the days of early July feel like a distant memory today. And an eerie, unsettling feeling has crept into the national psyche, indeed the global psyche, that perhaps what we've been living through isn't actually going to go away. Many now agree we are likely headed for an endemic infection, a scenario in which almost everyone has some form of immunity, either from vaccine or from infection, and that immunity lasts long enough so that people don't get really sick when they are infected. Just 2 weeks ago, in the Atlantic magazine, Sarah Zhang noted that we are probably headed towards a situation in which the coronavirus will likely become endemic in our world, circulating with the other common coronaviruses. This may sound scary to you. It certainly unsettled me as I read it. Like many of you, I long for the days when we can be together again and when we can host family gatherings without uncertainty and doubts. But what I had initially failed to grasp was that the transition to endemic COVID, as Sarah and her colleagues have documented, is not only an epidemiological one, but also a psychological one. As Zhang wrote, when everyone has some immunity, a COVID diagnosis becomes as routine as the diagnosis of strep or flu. Not good news, but not a reason for particular fear or worry. Endemic COVID-19 means finding a new, tolerable way to live with the virus. It will feel strange for a while, and then it will not. It will be normal. We all long for this. But what's more is that there may yet be opportunity in this possible future. No one can argue that COVID has radically reshaped almost all of our social systems and our healthcare system, to be sure. But with a transition to chronicity, perhaps some of the welcome changes brought on by COVID could be memorialized and made more lasting features of our future health system. Just as HIV once threatened Gloria's life, it also gave her strength. Could COVID, which once pushed our health systems to the brink of collapse, indeed be the source of the strength we need to help us finally remake our health systems for the better? I believe it can be. For too long, our systems have seen costs spiral upwards, lack of safety for our clinicians, overcrowding in our waiting rooms, lack of connection with our communities. We have seen more and more health concentrated among the wealthy and privileged, and less provided to those in greatest need. And we have seen more of our social resources and our national treasuries shift towards ever more expensive acute hospital care, robbing our children of their educations and our elderly of the home services that they so desperately need. Enough. We have needed a reset in healthcare for some time now, and COVID gives us the best opportunity in a generation to change the course of healthcare as we know it. It is time for a major reset. Every one of you listening here will be able to think of important changes brought on by COVID in your countries and in your systems that you hope your system will keep. I believe there are at least a dozen such changes, but here I will list only the 5 most important ones that I believe we should fight to preserve. That said, I'd welcome hearing from your lists, from your systems in your countries. What do you want your systems to keep doing as part of the big reset in healthcare that COVID has enabled? So with that question, let me share with you my top five things that we should keep. Idea number 1, we should continue to innovate differently. Last summer, at the height of the pandemic, a group of around 15 of the leading scholars and practitioners of quality improvement from around the world started a periodic conversation. And there was considerable concern that the slow, plodding pace of the PDSA cycle, an iterative cycle of change, was not up to the challenge of managing a global pandemic. But of course, an iterative cycle was exactly what we needed. Everything we did over the past year was one iterative cycle after another. But instead of a slow, plodding pace, the PDSA cycle was turning at a frenetic pace over the last 2 years. One of IHI's strategic partners is Health Partners in Minnesota, a medium-sized health system in a mid-sized city in the middle of the US. When COVID began, our colleagues at Health Partners were glad that they had invested decades of energy, effort, and money to build the quality improvement capacity that they had. When the pandemic struck, Health Partners CEO Andrea Walsh told me rapid cycle iterative testing was exactly what they needed. So Health Partners assigned all of their quality improvement assets to the challenge of COVID. How to create drive-through testing? They iteratively tested their way through it. How to vaccinate 1,000 people in a weekend? Once again, the PDSA proved handy. Our colleagues at Albert Einstein Hospital in Brazil did exactly the same thing. How to ventilate 10 patients with 1 ventilator? Iterative PDSA cycles of testing and learning led them to the answer. So how exactly did quality science allow us to innovate differently during this time? There were 5 preconditions that I think we will want to carry forward in the big reset. First, there was radical prioritization during this time. COVID pushed everything else aside. The list of hundreds of improvement projects and initiatives were put on hold, and everything, for at least a period of time, became about solving for COVID. Everyone was aligned and all in to help test and iterate towards solutions. Second was radical transparency. During the pandemic, many reported that they were rapidly sharing knowledge in new ways. For innovation to thrive, we need to combine information from different sources to create insights that allow us to reach novel solutions. One example, in Southwest Ohio, a group of healthcare organizations created a common data system to track and follow COVID patients. Housing agencies and public safety officials shared data with healthcare organizations to support contact tracing. We've seen in this era a complete rethink on how to share data transparently. The third crucial ingredient was radical collaboration. IHI has long had a philosophy of all teach, all learn, an appreciation that everyone has something to teach and everyone has something to learn. But rarely have we seen it demonstrated like we have during the pandemic. In New York, London, and in cities all across the world, major health systems that once competed built systems to share knowledge and work together. And this is the special cauldron in which new ideas come to take root. A fourth ingredient has been called radical exnovation of regulation. IHI's former CEO, Maureen Bisignano, used to say that you cannot innovate without exnovating something. By this, she meant that in the crowded landscape of healthcare, you can't add anything new unless you remove something that was previously present. We must eliminate as we create. And during COVID, so many regulatory obstacles were removed, from speed of vaccine approvals to where we can do testing and vaccination to where we can set up our ICUs. In a deliberate, focused way, we systematically exnovated obstacles to creativity, which allowed a waterfall of innovation. And lastly, we changed our mindsets, and we removed one final mental hurdle to innovating. We learned during this pandemic that going slow is actually a choice. Whether we intend it or not, whether we are deliberate in our choices or not, we actually can, and often do, set the speed of change. We get to choose how fast we go. We get to call the meetings. We get to schedule the follow-ups. That old maxim proved true. When we found the will, which we did during COVID, we actually really did find new ways. And this applies to almost anything from the way science is done to the way we vaccinate in a public health response. Slow is not a given. Slow is a choice. And we get to choose how and when to accelerate to get to the health system we all need and deserve. Okay, the second idea that that I hope we'll keep. In the past 18 months, we have profoundly changed the way we think about clinical practice. We have created what the National Academies of Medicine in my country had imagined when they dreamt of the learning healthcare system, which fundamentally fuses clinical practice environments with research to drive new insights. This was made crystal clear to me when I spoke to Dr. Anupam Sibal, the group medical director from Apollo Hospitals in India. Apollo runs 71 hospitals, nearly 4,000 pharmacies, and many other clinics and treatment facilities all across India. Dr. Sibal told me that in the early days of the pandemic, Apollo, like most major hospital organizations, did not have a coronavirus clinical practice guideline. And so, like a lot of us, Apollo wrote one and called it the Apollo COVID-19 Red Book. And they sent their Red Book to all 70 plus hospitals and encouraged clinicians in those institutions to send their feedback as they put the protocol to work. Within weeks, the protocol had been altered 31 times. And by the end of the first month of the pandemic, Apollo had established a regular, systematic process for dividing up the massive volume of COVID literature, identifying important critical elements that should alter the protocol, and designing a communication system for any changes to clinical practice across the whole system using WhatsApp, emails, and clinical case video conferences. The science was changing fast, new research was emerging every day, and practice was shifting. Apollo had built a true learning organization, a learning healthcare system. Dr. Sybil said to me in a video conference like this one, clinical culture will never be the same. This was reminiscent of a story I heard from a leader at the American College of Emergency Physicians. Emergency doctors, of course, were on the front lines of the pandemic, and they were not sure in the early days how to treat inbound patients with COVID. They started in those early days a one-page online wiki, online knowledge repository. Within weeks, that wiki had become 400 pages. Today, it is a massive online field guide, shown here, that is regularly updated with new knowledge as it becomes available. So now I ask you, if you are a patient living with heart failure, end-stage renal disease, a seizure disorder, or a cancer of some kind, wouldn't you want your clinicians to be building clinical protocols in the same way, staying abreast of the literature, building practice guidelines in real time, making real-time edits as the science matures, and rapidly disseminating that knowledge using the kind of communication systems that Apollo and these emergency room doctors have used? Patients should demand such clinical governance. Clinicians should want to practice with the latest science, and researchers should willingly submit their important and most crucial findings for inclusion in the clinical practice change. We need not limit the learning health system to COVID. It should be applied to every clinical condition that we treat. The third mega trend happening all around us is perhaps one of the most obvious consequences of the pandemic. And this is the radical acceleration of digitization. The pandemic has created a massive expansion of virtual care and telehealth, as many of us know. And the telehealth industry is now expected to grow from what was a relative cottage industry by healthcare standards to now a sizable role player in healthcare going forward. This has been across the board. In most countries, everything from how you see a pediatrician to how you see your mental health provider has moved to Zoom or another similar platform. There has been a clear shift in patient expectations and acceptance of tele and virtual health, with around 11% willing to try telehealth before the pandemic to 76% expecting their clinicians to provide a telehealth option in the future. And many people, both doctors and patients alike, have enjoyed the conveniences of not having to travel and take 2 to 3 hours off from work to be able to connect with their clinicians. Digital care has also enabled us to begin to realize some of the promises of artificial intelligence-guided diagnosis and treatment. Consider for a moment how good AI-guided diagnosis and treatment have become. In a recent study of 500 consecutive urgent care patients, when compared to physicians' final diagnosis and treatment plans, artificial intelligence gets the same answer 90 to 92% of the time. AI-guided algorithms in parts of Asia have been trained on millions of chest x-rays and can identify notoriously difficult to find tuberculosis with 95% accuracy in even the most remote parts of the world. And what's more, miniaturization and task shifting to advanced practice providers can allow for routine hospitalization to take place at home, with patients receiving essentially the same care that they would get in the hospital for common conditions like pneumonia, cellulitis, and urinary tract infections, but all in the relative safety and comfort of their homes. The other day, I was speaking with the CEO of one of the largest hospital-at-home healthcare companies in the US, and he said to me, the goal is not just to be an alternative to the hospital, the goal is to substitute for the hospital. But perhaps the most profound effect of our embrace of technology and its effects on healthcare has been the ability to supercharge, as I like to call it, primary care. For decades, we have sought to enable and transform primary care. But in the past year, I believe we have seen the future of how it can actually take place. Over the past year, IHI has partnered with an organization called Project Echo to bring COVID specialty clinical knowledge and quality improvement to over 9,000 clinical care locations all across the United States. Project Echo was inspired by this gentleman, Dr. Sanjeev Arora, a liver doctor at the University of New Mexico. Sanjeev created Project Echo because one of his first patients was a middle-aged woman with hepatitis C with several school-aged children. She had waited 8 months and driven over 300 miles to see him. And by the time of their appointment, her hep C had progressed to advanced cirrhosis, and a very treatable condition had become untreatable. She unfortunately died just a few months later, leaving behind her 2 children. Deeply affected by this tragedy, Sanjeev began teaching the primary care doctors in this woman's hometown, 300 miles away from him, about hepatitis C. He coached them via video conferencing platforms like this one to identify the disease earlier and begin treatment under his tutelage in their clinics close to their patients' homes. As you can imagine, this shortened the time to treatment and reduced waiting times throughout the system, and the results were stunning. As you can see on the slide, virologic response rates in primary care clinics coached by Sanjeev and his team were almost exactly the same as the treatment success rates in his university clinic in Albuquerque. Sanjeev had, in effect, supercharged the primary care in this woman's hometown with hepatitis C knowledge, and in so doing, he had reduced waiting times, improved the patient's outcomes, and substantially reduced delays that were costly and the complications that would come with them. The concept has now been extended to over 100 clinical conditions and to behavioral health integration across thousands of clinical settings all over the world. But with each of these exciting digital advances, including the possibility of finally supercharging primary care, there are human systems that are at the heart of it, that are required to implement them. And for those human systems, we found that we need the quality improvement methods, the tools that you all in this audience have, to ensure that the technology creates the impact that we might hope for. Okay, number 4. For years, clinical safety has been a backwater endeavor that we spoke about at this conference and similar quality and safety events around the world. Since the 1980s and 1990s, we have understood the risks to patients that must spend time with us in our hospitals. For years now, there have been designated patient safety teams in many of our hospitals around the world, and those hospitals dutifully report on a wide array of measures to the relevant regulatory authorities in our respective countries. Occasionally, too often, there would be a critical failure and the media would grab hold and we would pay attention to patient safety for a news cycle or 2 or 3, and then safety would fade back into the background. Never absent, to be sure, but also never fully on the front burner either. COVID changed all of this. For the first time in a long time, infection control expertise was a hot commodity. Maybe for the first time ever, infection control expertise was a hot commodity. Hospital epidemiologists were media darlings. Quality and safety scientists were regarded as mission critical. And in backwater infectious disease doctors like Anthony Fauci became national and indeed international heroes. My 5-year-old daughter was suddenly giving me a lecture on how to wash my hands and how to wear a face mask. With the shocking and demoralizing rate of COVID infections among healthcare workers, we extended the concept of patient safety to the safety of our workforce. For 2 years now, IHI has been working with a group of 30 health systems focused on identifying evidence-based interventions that enhance physical and psychological safety, and then helping them to implement these actions to reduce harm and injury to their clinical workforce. The group tracks serious safety events, serious harm events with the workforce, and their data indicates that as COVID began, we saw spiking rates of workforce harm and injury. To help mitigate that impact, IHI published guidance on what we called psychological PPE for healthcare workers to help us all support one another during these difficult and troubling times. Earlier this year, IHI launched in the US, alongside 10 hospital CEOs, a CEO coalition to improve physical and psychological safety in the workforce. And you can see here on this slide the principles of psychological and emotional safety, health justice, and physical safety that these CEOs are committing their health systems to. Surely a version of the CEO coalition could be replicated in your country right now that would promise to address what matters most to healthcare workers and be part of how we recover from this pandemic. But despite the fanfare and energy around infection control and epidemiology during COVID, rates of many of the traditional harms that befall patients rose during this time. Data from the CDC in the US showed rising rates of central line infections, ventilator-associated pneumonias, falls, and other injuries and harms, which means to me that we need a reinvigorated focus on safety, one that emphasizes the safety of our clinicians and the safety of our patients, one that emphasizes novel applications of safety concepts to digital health, home-based care, and diagnostic safety. One that embraces safety not only as a series of technical checklists and clinical bundles, but one that finally recognizes safety as a complex socio-technical phenomenon that requires more complex thinking and understanding to get through to a new and better level of safety than we have presently seen. The last idea may be the most important of these ideas for what we should preserve in our systems going forward. 20 years ago, the Institute of Medicine invited us to consider 6 aims for better healthcare: safety, effectiveness, efficiency, patient-centeredness, timeliness, and equity. 2 decades later, we still have a lot of room to improve in all of these, but none more so than equity, or equality, as it is sometimes known. Bearing witness, as we all have, to the inequities in those who are affected by COVID in each of our countries, and the global inequities we are now seeing play out in vaccine availability and distribution, we can no longer contest the ravages of inequities and inequalities on our healthcare systems and on the health of our populations. We can say now, confidently and certainly, there can be no quality in healthcare without equity. There can be no high-quality health system that systematically excludes many from the benefits of that system. For some time now, I've been studying the work of John A. Powell, a professor of law and ethnic studies at the University of California at Berkeley. Powell articulated the framework of what is known as targeted universalism. This is a theory that suggests that the better and perhaps more efficient path to universally held societal goals may be through the use of targeted strategies that help advantage those who have been systematically disadvantaged. I think that this theory will help create far more health, far faster, and far more distributed than anything that we have currently imagined. Let me tell you a story of how this may have played out during COVID that we may wish to recreate going forward. Consider for a moment the successes of our colleagues at South Central Foundation in the state of Alaska here in the US. These colleagues began their COVID vaccination efforts by focusing on the most under-resourced Native Alaskan and American Indian populations in their catchment area. We all sought herd immunity. This was the universal goal, but their strategy led to a targeted and inclusive approach to reach those that were hardest to reach first. And that strategy worked. It quickly led, for a time, to the highest per capita vaccination rate in the country. If we focus on the most marginalized, it turns out, we can actually get to our universal goals faster and even more effectively and efficiently than ever. I could go on for a while about this theme, but for now, let me offer that every one of us listening to this conference today can ask this one simple question as we go about our work. Have we looked at our data on whatever clinical outcome matters to us most, stratified by race, ethnicity, and language? In every clinical setting that I've worked with over 2 decades and over 30 countries, this simple question, this simple analysis almost always reveals powerful root causes and opportunities for improvement. So there you have it. 5 key ideas that would remake our healthcare system into the health creative system that we deserve. 5 key ideas for a big reset. And the amazing thing about this is that all of these are already being done right now in most health systems in the world. We don't have to start from scratch or create these de novo. COVID, for all the loss it has left us with and all the havoc and dislocation it has created. COVID has perhaps given us the first real chance in our lifetimes to finally heal our health system. Thank you.